Forval.
Hi, good morning, everyone. We would like to welcome you all for the Four Valves birthday party. First of all, we would like to thank all of you for supporting us to maintain this great network of medical education dedicated in structural heart therapies. And now I would like to hand over to Pablo, our great colleague and moderator. Pablo, good morning.
Your mic is off, Pablo.
Hi, Gustavo. Hi there. Hi, everyone. It's a great opportunity to be here with you guys, to learn from the best, I would say. And this is fantastic to join the guys from Italy, US, Argentina, Spain, and Brazil. This is fantastic. My co-moderator would be Márcio Montenegro from Rio de Janeiro. Hi, Márcio.
Hi.
You want to say some words to the guys?
Hi, everybody. Morning, everybody. Hi there.
Okay. So let's move on. I'm gonna present our presenters and moderators. I'm gonna start with Professor Maisano, Francesco Maisano from Milano. He's the director from the Valve Center there. And after that, we have Professor Mohammad Sarraf, interventional cardiologist from Mayo Clinic in USA. After that, Professor Rodrigo Loureiro is from Vigo, España, interventional cardiologist at University of Vigo. Professor Adolfo Ferrero from University of Córdoba. The intention that when I talk to Gustavo talked to me, the objective of the session after from being a birthday and from the Four Valves and a special session, will bring some innovation and innovators in the field, and they are going to present us their breakthrough devices and what they think some procedures that's going to be in the future or in the present special breakthrough devices from them. So I'm gonna start with andiamo a Milano, allora, Professor Francesco Maisano. Professor Maisano, everybody knows him. He's kind of mentor for valves, I suppose. And he's going to talk to us about the cardio valve in tricuspid valve. Professor Maisano, please.
So first of all, let me spend a couple of minutes. I know it's not in the agenda, but a couple of minutes to congratulate the Four Valves community. Not only to establish Four Valves, but I think also those who are supporting this effort. It is a great project. Sometimes for me it's not easy to follow you because you have some language barriers. It's not for everybody to understand what you do and what you say, but I get the feeling, which is a mixture of innovation, but still with a lot of humanity, a lot of human touch. You mix our professionality in terms of technical professionality with the other side of our profession, which is very human, very touchy. So I really congratulate with you, and with this I will share my screen. so that we can hopefully working. Yes. And okay. Tell me if you see my screens, because I don't see you anymore. Is anybody can say yes?
Yes.
Yes.
All right. So the device picking, my favorite breakthrough device in 2022-23. Obviously, it's a lot of it's a difficult choice. It's like you go in the morning to the cafeteria, and you really have a lot of options. So it's not easy to choose one among so many innovative devices which are pushed into the system almost every week. This is my disclosure slide, and on the disclosure, you already understand why I talk about one of these devices. To be honest, I don't do it for advertisement. I really do it because I believe in this project, and also because I have deep knowledge inside of this project. And I'm talking about tricuspid, and we talk about cardiac. But tricuspid disease has been for many years left behind, let's say. We always thought that this valve was not so impactful in the prognosis. And since 5-6 years, I think for many of you who have been with me in Zurich, we were really at the beginning of this effort of entertaining interactions with the right side of the heart. And in this 5 to 10 years, we learned a lot. We've been learning that there are many different phenotypes of tricuspid regurgitation. We learned that tricuspid is often not three cusps, but is very often more than 50% of patients have more than 3 leaflets. We have been evolving imaging like hell. I mean, we see this valve in different modalities, and also we understood that we need a different quantification modality, because this valve usually is working under low pressure conditions, but has a lot of regurgitation, and we still don't know exactly how to manage this different behavior compared to the mitral valve. In the tricuspid valve, we have been using many devices which have been developed initially for the mitral. And obviously the one which is mostly used, because widely available, because it's always a kind of an off-the-shelf device, is the transcatheter edge-to-edge with basically 2 major devices, mitral clip and Pascal. And we know that this is working pretty well in many patients, not in all patients. There is still a significant number of patients who are responding not perfectly to this approach. And more will come. There will be again, annuloplasty is coming back. You know, I've been yesterday working on Cardioband generation 2 ideas. But obviously replacement can play a role also in this field. And when we talk about replacement, I will talk about cardiovalve, but please forgive me if I use only one of these valves. I think I'm fond of many of these valves. There are so many different devices, but I will focus on the one that I know the best, and share with you what are the strengths and limitations of this procedure. Strength. We are using now a device which has been adapted for the right side of the heart, using a device which is exactly identical to the mitral. This is not uncommon, to be honest. The surgical valves we use on the left side, they are the same that we use on the right side, and there is not much difference. This device has been always designed for transfemoral delivery, with very low protrusion in the outflow tract, although in the right ventricle, as we know, RVOT obstruction is not an issue. But there are many characteristics of this valve which are very useful for the right side. First of all, it doesn't need a lot of radial force to be implanted, and that brings you to two major advantages. Advantage number one, you allow the valve to sit also in large anatomies, and also it allows some degree of reverse remodeling also of the base of the ventricle. Imagine if you block the base of the ventricle with a very strong device which needs some radial force, you are going to impact also radial strength. And finally, having little radial force needed is probably protective from pacemaker implantation. We have seen other devices have been associated with a large number of implants. Cardival, still limited experience, not even 20 patients done till now, but only one patient received the pacemaker afterwards. Valve replacement in most occasions is a very simple concept. You get into the valve, in this particular case, you open some ventricular legs which are engaging the subvalvular apparatus. And after the subvalvular apparatus is engaged, just like you do with a mitral clip or with a treat clip or Pascal, where you engage two leaflets, here you engage the whole apparatus as much as you can. And finally, you release a atrial cuff. This device comes in different sizes and covers diameters at this moment up to 55 millimeter with a very large valve. Is a 29 millimeter diameter valve, which is important for tricuspid. In this animation, I will show you quickly how this works. It is a device which has a steerable system which has been adapted for the right side of the heart with some elevation capabilities. Not yet ready for septolateral maneuvers. This is a little bit of a limitation at this moment. It will come in the generation 2. Once the device is in the ventricle, the ventricular legs are open, and then the device is retracted. It fits into the system and then releases this atrial flange, this atrial cuff, sorry. The atrial cuff is doing two things. One is improving sealing, and two is sandwiching the leaflets between the ventricular legs and the atrial cuff. After this is done, the valve is already functioning. And the valve is usually having a good sealing. Okay, so wait a second. I have a small presentation of the first in man, just to show you a representative case. This was done 1 year ago, April 7th. It was a female patient. Almost every patient is female at this moment, with severe TR and moderate MR. You see now the initial phase. Now we have some little differences. We are not placing the wire anymore in the pulmonary. We use a Safari already in the right ventricle. But basically the concept is the same. We advance the device into the right atrium. And once we are in the right atrium, we work usually without the wire in most occasions. So that we maneuver this device just exactly similar to a mitral clip. The legs are open in the atrial side. Once we are coaxial, we advance the device into the ventricle, just below the leaflets. We don't go too deep. We stay anterior to the anterior papillary muscle. We pull back. And as we pull back, we engage as many portions of the valve as possible. So we try to reach all three or more components of the valve leaflets. And after that, the atrial flange is released. You can see now. So the cuff is pulled back. It's a self-expanding structure. The atrial flange is released, and the valve is already ready to function. The distal portion is released as well, and in a few seconds, cardiac output is reestablished. The patient remains pretty stable during all the phases of this procedure. The tricuspid valve works obviously perfectly. There are very limited PV leaks in few patients, sometimes most occasions coming from the anteroseptal commissure where the valve remains a little bit far away, which is also good to avoid any AV block because there is not much interaction with the conduction tissue. You can see a tiny leak here in the anteroseptal commissure. Not all patients have this. Results are pretty good. We had only, unfortunately, the first cement was, this, what I showed you was not the first, was the second, sorry. Anyhow, the first cement, unfortunately, did not survive after the procedure because of after all mismatch with the functioning valve, but all the other patients have been surviving this procedure. The first case was done in an emergency situation, so it underlines the issue of patient selection. And you can see here in the very initial phase, different operators may have different time of procedural times, but the learning curve goes down very quickly. Already the second procedure is done usually very fast. Most of the time is spent on understanding imaging and specifically to quantify leaflet insertion in a multi-planar reconstruction. Now, I will skip the take-home messages of the cadaver because now I talk about a bit more broadly, and also I tell you why I was picking this device. Besides the beauty of the device, which is a beautiful device, I decided to show you a tricuspid replacement because tricuspid replacement together, I would say with repair, is the gate opener for innovation in the next 5 to 10 years. We are going to study the right side of the heart and learn a lot of things. This is, for instance, the amount of right ventricular remodeling that you obtain only after 3 months after you implant this kind of valves. But there are many other topics to investigate. As I told you, the first case died of somehow after-op mismatch. It's a problem that we need to understand further to understand the limitations of replacement. As you can imagine, after-op mismatch in the right side is a bit different from what we see on the left side, and also it will not probably happen in patients with undergoing transcatheter edge-to-edge, while it could be a problem for patients undergoing replacement. We are learning a lot about the venous system. Is much more difficult than we thought. If we want, we can elaborate afterwards, but if the overall physiology, pathophysiology of chronic TR is still something to be completely written, including understanding the predictors of right ventricular function, what to do after the procedure in terms of anticoagulation, how to optimize these patients prior to the procedures, and how to select patients for different techniques. See, there is a lot of limitations and gray zones for replacement, and these gray zones and limitations are today also one of the reasons why I'm very involved and very interested in participating to these early feasibility trials, because we learn a lot. As I told you, the after-op mismatch and futility is one of the issues, and again, the important point is that there is no one single patient which looks the same to the other one. We learn there are many different subcategories, lot of different phenotypes, and each phenotype probably is associated with different behaviors, different prognosis, and maybe in the future will need different techniques. The issue of the load mismatch is becoming increasingly important. There are many ways to predict RV function after these procedures. Probably the one which is most promising is the RV-PA coupling, which is basically trying to give a measure of the RV function relative to the afterload conditions. But again, the other issue is that we still see many patients who are referred too late. And in these patients, we are in front of heart failure patients with chronic low cardiac output. Again, these are patients we were not seeing before. We were not even watching to these patients before. If they were coming to our hospital, that we were just saying, you are too late. Today we have options, but we need to really learn a lot from also from some exams which were not done in the past so often, and now we need to reestablish our skills and knowledge around things like right heart catheterization. The issue is also another question: do we really need to clear completely TR to improve the outcomes? You may say yes, but basically, if you look at the TR improvement, which is obviously very good with the replacement, and only 60% of patients have a real reduction of TR after clipping or cardioband, well, the point is that if you look at the NYHA class improvement, there is no difference between replacement and repair, as well as there is no much difference in terms of improvement in functional classes and functional capacity. So the question whether we should really abolish in all patients remains. There is the question of anticoagulation, which is still a problem. Also, when we think about long-term outcomes, there is an issue of AV conductance in some of these devices. For instance, in the experience with Evoke, there has been a pretty high rate of permanent pacemaker, 10%. And then there is a lot of anatomical limitations that will not be, I don't want to be tedious, but the size of the annulus, the position of papillary muscles, the angle between the tricuspid valve and the IVC, all these issues are very important. That brings me to the final point that, as usual, there is a strong need to master all alternatives, including obviously replacement, where we will probably balance the advantages of a complete correction of TR with the disadvantage of using a prosthesis and probably having something which is potentially a little bit higher risk than just repair. With this, I would say I would end my choice the discussion saying the future is full of surprises and exciting discoveries, and thanks to this new innovation, we're going to learn a lot also about the pathology that we are at the moment treating without knowing all the details of the natural history. Thank you very much, guys, for your attention.
Bravo, Professor. Fantastic device indeed. What I'm gonna do, if I may, I'm gonna ask Professor Mohammad Sarraf to make a question for Professor Maisano about this device and what do you think and for the future. And please, Professor Mohammad.
Thank you very much, Professor Maisano, as always, truly illuminating. You touched upon a number of questions that, as you were describing, came to my mind, one of which was leaflet thrombosis, which, vast majority of these patients, at least looking into these EFS studies, we see that 90+% of these patients have AFib. So I think vast majority of these patients have to be on anticoagulation anyway, but I think the bigger question comes when, as we have indication creep that we always find with any transcatheter technology, or for any technology for that matter. If we end up doing this procedure in patients who are probably moderate or moderate to severe and they don't have AFib, do we have to put them on permanent anticoagulation or not? And then the other question I wanted to ask, which is probably more of a prepping for the case. Do you consider prehab of these patients, bringing the patients days, if not weeks before, diarise them, and do comprehensive hemodynamic study, cardiac MRI? What's your approach to choosing your patient, and also how do you prep the patient before the procedure?
Yeah, I think so to mention the anticoagulation, first of all, we don't know yet exactly what will be the anticoagulation regimen for these devices. Evoke has been proposing a standard practice. For instance, at the moment, Cardival is still in the earlier stage. We are in the compassionate use, so every hospital is left free of managing anticoagulation as they want. But I have also to say that I think 100% of our patients are in AFib, so there is no big discussion. But it's not a minor issue when we think about the future. If we expand and progress our mind in 5 years from now, I think all those centers who are offering tricuspid interventions, they see a change in patient referral pathways. We see patients coming earlier. We see patients who are maybe in permanent AFib, but maybe not since many years. And so potentially patients who may recover from AFib. We see patients in sinus rhythm as well. I've seen several TR in sinus rhythm with atherogenic TR for some reason. I don't know exactly. I mean, this could be another subcategory. So when we think about this population that today, potentially you think again about surgery. So in these patients, you reconsider surgery. But in 5 years, my candid opinion, there will be no surgery done anymore for tricuspid because all these devices are basically reproducing surgical tools. So when we go in that direction, the earlier you treat these patients, the more you see a role for annuloplasty, probably more than leaflet repair, to be honest. We'll see what happens. It's still something to be understood. As far as the prehab, I think there has been a lot of blah, blah, blah about prehab. Obviously, it makes a lot of sense to do it. If you have a patient who has is decompensated, you should not treat these patients. Actually, our first in man unfortunately died 3 days after because this patient came with acute renal failure, acute liver failure, and she was in acute low cardiac output when we operated. And from that patient, I learned something which is very important, not only about prehab, but also post-op procedure. What I think we don't know yet well is that the physiology of the venous system when we work on the right side. We think left, but we are right. So in the left side, for instance, it's very often the case that if you have massive MR, you see a huge V wave, and that you treat the MR and V wave disappears. And you reduce mean pressure dramatically in many patients. When we treat TR, you see V waves which are a little bit less evident. That makes sense because it's a low pressure system. You treat the TR, you replace the valve, so 0 TR, and still right atrial pressure remains very high. Because the venous system obviously is a systemic venous system, much larger, as soon as you reduce the pressure, and usually you have to do it either with diuretics or even better. In many patients, I do acute, I pull blood out up to almost 1 liter. And if they have a normal hematocrit, I just throw it away. If the hematocrit is low, I wash it and I give red blood cells with hemonetics. But this acute unloading is very beneficial for the right heart, and is the only way to see right heart to recover immediately, the right ventricle to recover immediately after these procedures. And in the next days, you give diuretics, and they still remain with elevated right atrial pressure because the water is coming. So I think, yes, we need prehab and bring the patients as euvolemic as possible, but you cannot go below some levels because they need overload to maintain forward flow. So it's normal. These patients will come always overloaded because the right ventricle is huge and they have a huge amount of backflow. So you need to be overloaded to survive. Once you abolish the regurgitation, then you have a different modality. And so we're talking about pre-heb, but we will need to start thinking about post-heb. Something in the very first 2 or 3 days, in those patients who are coming in more difficult conditions, I truly believe we need to learn how to manage these patients in a more standardized way.
Great summary.
Okay.
So actually, I'm sorry. Was someone, Rodrigo, did you have a question?
I'm sorry to interrupt, but in interest of time, we have to move to next presentation. Sorry for that. Okay. So now, vamos a España, Vigo. Professor Rodrigo Estévez de la Universidad de Vigo is going to tell us about the transeptal amend, is the breakthrough device for the mitral repair, transeptal mitral repair. Okay?
Thank you, my friends. First of all, as Professor said, really congratulating this happy birthday for the 4 valves. I think it's an amazing platform from all LATAM to create not only teaching, but also spreading the knowledge we gain all these years that you are gaining more and more every day, and also to create awareness in the patients and to referrals and to increase the treatments that at the end is important. So congrats for this amazing platform. I'm really more than happy to be here. So I will present now what I think would be an interesting device for, hopefully I can share this, okay. This one. You see the...
Perfectly.
Okay.
Yeah.
So when Gustavo asked me to present something in the Innovator and told me that Francesco and Gilbert will be here, I mean, they are one of the biggest innovators in the world. So, I mean, just a standard interventional cardiologist. So I have to think a little bit on what will be an interesting device for the next couple of years to be there. And as I learned many years ago from Professor Maisano, when all these transcatheter mitral and tricuspid intervention started, at the beginning, and he presented earlier, that we will need kind of toolbox for a valve that is a mitral valve that is complex and several mechanisms can be implicated in the disease. From that early concept, we moved just, with the evidence and the practice just to the concept of edge-to-edge. But now that the technology, I think, is mature enough to move again to different targets in a minimally invasive way, as a transeptal procedure. So my device picking for this session will be a complete annuloplasty device that will be implanted transeptally. It's called Amen Ring. So first, I have to say that I will present this, but all the credit of this device and presentation and the first in man is owned by our good friend Bruno Melica from the University Hospital of Gaia in Oporto. That was a member of the CAS family, of course. That was the guy that did the first in man of the transeptal amend ring in the world. So, as you know, mitral annuloplasty is the key element in surgical repair. All the surgical repairs end up with annuloplasty ring, and this is used sometimes to treat the mitral regurgitation in some cases, like functional ischemic or non-ischemic cases, and it stabilizes the repair of degenerative cases. So it's kind of a mantra, and we have heard this for many years from surgeons that transcatheter therapies will not be good enough until they can reproduce the annuloplasty ring, complete annuloplasty ring, as surgeons do. So this device, the Amen transeptal system, mimics the surgical gold standard of the annuloplasty ring. It's a semi-rigid D-shaped complete ring. We have some incomplete bands like the cardio band that work well, but this is kind of a step forward in the development. It has a robust anchoring mechanism. You have the ability to unlock the device and retrieve it until you start the anchoring stage. We have 4 sizes of this device to adapt to a wide range of anatomies and sizes of the annulus. And you can use it as a standalone therapy in those cases with functional matter regurgitation. Probably atrial FMR could be a really nice niche to treat these patients, or in some ventricular FMR cases. But of course, you can use it as a combo therapy with edge-to-edge or with neocords implanted transeptally or transapically. Could be interesting as well. So the aim of this device, of course, is to reduce the anterior-posterior dimension on the annulus and enhancing the coaptation and maintaining the repair. The system has an steerable introducer sheath that is 26 French venous access. And we have 2 catheter delivery systems, the transeptal sheath and the guiding catheter that can be moved in 3 planes of the space. And we have the inner catheter that's still torqueable and allows to place the ring in the right position. Now we have an animation how the device works. It's introduced completely free in the left atrium, and the device circles itself and locks in the basal part as is the final configuration. Then you have to steer the device down to the mitral valve. And the first thing we are gonna do is to deploy the trigon tracks that will hold the device in the trigons. Once we have the trigon tracks implanted, you can steer the device to the posterior part. And once we reach the posterior part, we can deploy the anchors as you observe in the figures. And as long as the posterior part is correctly anchored, then using the trigon tracks, we will move the device all together to the anterior part. And when we make contact, we will deploy the anterior hooks and remove the trigon tracks, and then we can release completely the device, implanting the full ring. So we have some publications or some result report about the version of this device, but in the transapical way, with interesting reduction in mitral regurgitation and diameters. But I think the way of doing it is just moving to the transeptal field. That is the way of be really minimal invasive. So first case, we saw here the lady that gave permission to show this picture, and our good friend Bruno Melica with her. Is a 78-year-old small frail lady with COPD, quite of advanced, permanent AF, and renal dysfunction. The patient presented with heart failure in NAYHA class functional 3, progressive worsening. ECG showed atrial fibrillation with normal ventricular rate and no left bundle branch block. And TTE showed significant MR. Functional classification for Carpentier type 1 annular dilation, probably atrial FMR, with a dilated annulus, 38 millimeters, moderate AR, moderate TR, and elevated systolic pulmonary pressure with preserved left ventricular and right ventricular function. No coronary disease was observed in the angiogram, and patient was on optimal medical therapy. In the transesophageal echocardiography, we see an annular dilation with 39 millimeters, a significant mitral regurgitation with a regurgitant orifice of 31 millimeters square and a regurgitant volume of 68, so really significant. Central jet, we have some posterior leaflet indentations that can make the treatment of the standard edge-to-edge quite difficult. Mild to moderate TR, mild to moderate AR, and preserve LV function. Of course, to decide the size of this device, we need to do a CT scan to properly measure the annulus. In this case, annulus was the mean measurement of the diameter was 38. Yeah, as you see as well, the annulus is quite rounded in these atrial FMR patients, and the CT scan is also important to assess the distance with the left circumflex. We need to have more than 3 millimeters to avoid the impingement of the circumflex by the anchors of the device. In this case, the size of the ring that was selected was the L. So in summary, high-risk surgical patient, suboptimal anatomy for edge-to-edge repair, and it was decided to do the annuloplasty with this device. The setting is a standard one. Venous access is percutaneous, no need to cut down. It's just 26 French, and it was closed by 2 Proglide. And we need as well a catheter placed in the left coronary system, just to put a wire through the circumflex to mark the annulus. Position of the transeptal puncture is kind of standard in inferior and posterior position. This is the baseline echo during the procedure. Of course, the effect of the anesthesia lowers a little bit the severity of MR, but as you see in the true view, you have several indentations in the PML that makes the tear a little bit more complex. So now it's coming the ring, as you see, is coming kind of unfolded, and it's as long as you put it into the in the left atrium, is starting to fold, and eventually it will lock in this position here. That is quite important, that they lock, and you can now steer the device down to the annulus. Here is the steering down of the device, that we can move in the 3 directions of the space, and here the device is positioned mostly in the correct position in the annulus. You see the circumflex is marking the mitral annulus. In this point, when we have position, we advance the trigon tracks, as you observe here, that will hold the device in place to allow us the posterior movement. And once these are in place, we are going to shift the device to the posterior part, as we can observe in this video. And once we have contact with the annulus there, we will deploy these hooks, as we can observe in this position. There is a deployment of the posterior hooks that anchors the device to the posterior part of the annulus. Once the posterior part is held in place, then we'll tilt anteriorly the device and we'll deploy the anterior anchors that you see here in a while, and this attaches the annulus, the device completely to the anterior annulus. And once the device is attached to both sides, then you will remove the trigon tracks, and the device is correctly positioned, as you can observe here, with a significant reduction in MR and no damage to the left circumflex. This is the control of the patient with CT. The evolution after the procedure was completely uneventful. And this is a CT scan control. As you remember earlier, the distance between AP was 38, now it's 26. So a huge reduction in the anterior posterior diameter. And this is the control at 3 months, so preserve ventricular function and mild mitral regurgitation, so a successful procedure. So in conclusion, annuloplasty could be a key element for evolution of these new therapies as transcatheter, as we're moving to the transcatheter field. The main transeptal ring provides a totally percutaneous complete annuloplasty, anteroposterior annular remodeling. We have a wide range of anatomies. You can use it as a standalone in some anatomies, or as a combo therapy with a recurrent mitral regurgitation prior mitral clip, or just to use it as a combined procedure in some cases with edge-to-edge repair, and could be a really interesting device to implement in your toolbox for mitral valve repair transcatheter in the future. Thank you so much, guys.
Thank you, gracias, Rodrigo. Really amazing and fantastic job. I'm really thrilled about this one. This is really a great work of engineering in medical field. This time, I was talking to Gustavo and Márcio. I think we should ask Adolfo Ferrero to make a question for Rodrigo and to make your considerations of the device. Please, Adolfo.
Thank you, Rodrigo. Your presentation was amazing as usual. I want to get from you the impression of the difficulty of using this device in comparison with mitral clip. You are an expert on mitral clip, so I would like to understand how difficult it is to manage this device in comparison comparison to MitraClip, for example. If we have 1 second, I would like to Francesco to give me a feedback about this complete annular ring in comparison with Cardioband, that you are an expert, to understand how difficult it is to manage this device in comparison with Cardioband. I have the opportunity to see you working with Cardioband a lot of time, so I would like to understand the difficulty of this device.
So Adolfo, it's a good question. First of all, the concept here is relatively different in terms of anchoring. The amend system has these 2 anchors in the trigons, which are probably the only anchors which are going into the real annulus. All the rest is implanted supraannulally. And when you implant it supraannulally, you are actually putting sutures in the left atrium. And you obtain, obviously, you drag tissue and you create basically annuloplasty. Now, the problem with annular sutures, even in surgery, is that in some cases you may have durability issues. You may have detachments. So I don't know I'm not in this program deep enough, and I don't want to say something which is not supported by evidence. But I would be worried about durability, particularly if you take patients who have a massive annular dilatation. On the other hand, I think I've been following Amend for many years, and I see that now is a pretty standardized approach. I think it is doable. The initial device was really not, it was a lot more difficult, and probably it would be unsuccessful in many cases, trying to grab tissue here and there, just pulling, pushing. Now it makes a lot of sense to have 2 anchors in the strongest area. I would like to know if the medial anchor could also lead some AV blocks. You need to know that. But on the other hand, in selected patients, it looks easier than Cardioband at the moment, and probably more efficient in terms of annular reduction. Although the durability, Cardioband has been shown to be very durable in terms of fixation. Not in terms of MR reduction, because that is another point. Rodrigo, what do you think?
Yeah, I mean, taking the Adolfo question, steering, I mean, we have a lot of experience with MitraClip, and it has been here for many years, so it's really easy for us to steer down the device and to predict more or less what the results could be. So from a device-friendly user, I mean, MitraClip is much more friendly. But you know, we also experience not so very good results in patients with largely dilated annulus, and these patients with atrial FMR. I mean, we have treated several of them, and results are okay, but you need to pull a lot of effort to try to create strong grasps to bring the annulus a little bit, because it's really huge annulus. So maybe in those patients it can work. Of course, this has only been implanted once or twice in the world, I think, from the transeptal perspective. And of course, we don't have follow-up. We have this transapical follow-up of 14 patients. That is very little information. But probably it could make sense to try to use it as a first line in some selected populations, as I said. Atrial FMR, maybe not with so huge annulus that can at the end detach the device at some point. Or I can recall as well maybe these Barlows where there are huge problems with the annulus, and sometimes when you reduce the annulus, you can also enhance coaptation and reduce MR. I mean, still, of course, very limited experience. I think it can be done. It doesn't look like super complex, but of course we need follow-up, and I copy all the comments from Professor Maisano, because he knows how these devices are designed, and of course the limitations are there.
Okay, Professor Sarraf, wants to make a quick question, please.
Sure. So it's to either one of you. So thank you, Rodrigo, for this amazing presentation. Most of the publications of Alfieri stage has been obviously done by Professor Maisano and Professor Alfieri. Let's do a thought experiment. In the ideal world, let's just put the cost aside for a second. Let's say that we have free money to do whatever we want. Would you ever consider putting, and I don't want to say MN, but a transcatheter band or ring system along with a microclip? Because according to at least the Alfieri papers, the best outcomes in patients were in the ones who got the Alfieri stage and the mitral ring or band, for that matter. And it also takes away using an XT device. We can actually use NT for vast majority or NTW for vast majority of the patients, and then we can address two pathologies at the same time.
Yeah, I would answer first and then let the experience talk. I think it makes sense to combine these procedures if you can do it easily and you don't pay attention to the money. I mean, it makes sense to address annulus and leaflets, of course, that probably create a more durable repair than only edge-to-edge. Although we know that MitraClip or Pascal is not exactly the same as Alfieri stitch plus. I mean, there's something different there. You pull as well the annulus. So it's a different. It's based on the concept, but it's not exactly the same. But in some cases, it might have sense completely to use both devices.
So it's a question that is recurring every few years. Particularly now that we have replacement, we should probably rejuvenate this question. Because obviously the combination of two devices is more cumbersome. It's two procedures or two steps. And secondly, more expensive. On the other hand, it could be safer than replacement because you avoid the issue of after mismatching the dysfunction. And you are not pulling too much the indication on both sides. I mean, if you have a patient with tethering and you put a too small ring, you increase tethering. If you have a patient with large annulus and you use large legs, larger devices, you may break the leaflets. So it's a bit counterintuitive, but probably having two devices would probably reduce the risk of complications and enhance outcomes. Also, I can tell you, it happened to me a few times, honestly, but it happened to reoperate patients who are being treated with MitraClip. And in some cases, just annuloplasty added on these patients, leaving the clip inside, was successful. So there are many reasons why a combination would work. If you talk to industry, and I've been talking to industry for ages, now Edwards has this option in their hands. And obviously they keep it in their background. But I tell you why they will never say never, but they don't speak about this often because it goes against the holy concept that device works. Okay, if you say that you need two, it means that one, it doesn't work. So it's a little bit bad marketing. And also this concept, yes, it's true. We reduce the annulus. It is totally true. If we use longer legs, specifically if we work with, I don't think it happens with Pascal because it stretches. But with MitraClip, you really can impact the specifically tricuspid annulus. You can see very often. And I have a wonderful case I need to download. I did last week on atrial FMR, where the annulus was fibrotic, and in 3D you could see that a line around the annulus, and then you can see really how the annulus becomes like a W. But still, that reduction happens in the area where you don't need the reduction, because the annular reduction happens where you already have the edge-to-edge. On the sides where you have the clefts, it remains dilated. So it's not efficient annular reduction unless you put multiple clips. So yes, I believe that annuloplasty should grow, should become standard practice. And if we really want to say structural interventions are replacing surgery, we should not reinvent the wheel and reproduce what surgery has been established for many years in most of these patients.
Are we going to the next?
Yes, we have to move. Sorry about that because of interest of time. I want to just ask very quickly, Márcio, do you have any question or questions from the chat, or do you need some comments?
Yeah, we have a question back to Professor Maisano, but I think that we could leave for the final. I think that we can watch the presentation of Professor Gilbert Tang, and at the final we can discuss about.
Pablo, you have some problems with your voice.
Yeah.
Unfortunately.
So just a second. Before we go to the Professor Tang presentation, Juliana, who is our COO at the Four Valves, will give you a message. Juliana?
Hello, everyone. Thank you for the amazing session. There is no best way to celebrate. Thank you for the panel. Thank you for the presenters and the audience. Well, I'm from the backstage, but today I'm here to invite you all for our first presential meeting that will be held in October in Brasília. Four Valves for Heart team. And we from Four Valves hope to see you all friends in Brasília this year. Okay, thank you very much.
Thank you, Juliana. Nice to see you. So now we can put the video of Gilbert Tang. Professor Gilbert Tang is in a meeting for the Apollo trial, but hopefully he will be in 15 to 20 minutes together with us, joining to discuss with this amazing panel and presenters. So Pedro, you can put the video on.
Hello. Thank you for inviting me to give this presentation. And I want to talk to you about the NeoCord Nexus program, which is an early experience of a novel transcatheter mitral chordal repair system. So the NeoCord DS1000 was the first transapical chordal replacement system. And there have been over 1,700 patients treated worldwide, 600 plus patients in clinical studies, and has generated over 60 publications. Now, the NeoCord Nexus is a purely transeptal percutaneous system, and there have been first in human cases successfully performed so far, and the early feasibility study is about to begin in the United States. In terms of the R&D pipeline, you can see that here, the transeptal chordal replacement system can actually lend itself very nicely to an edge-to-edge repair system as well, as you see here. And so far, preclinical studies have been done with 30-day results. And finally, there's a new generation transapical chordal repair system called the UltraCord for patients who are not amenable to transeptal chordal repair. And this is another alternative to these patients who can tolerate a transapical access procedure with a smaller profile, and the bench testing and preclinical testing have just been completed. Now let's talk about the NeoCord Nexus for a minute. So the design goal of the Nexus system is really to allow independent steering and for precise navigation to the target mitral pathology. And the idea is that it's based on clinically proven technology from the DS1000 transapical system. It is the same in terms of ease of use and safety. You can precisely identify the pathology and be able to place a primary cord. You can reverse or retrieve it. You can put multiple cords on a single pop brain muscle anchor. You can mimic a physiologic repair with native mitral valve function. There's no issue with mitral leaflet erosion. You actually simplify the beating heart tensioning with transeptal approach. And finally, of course, with a chordal repair system, you preserve all future repair or replacement options, whether it's surgical or transcatheter. So the leaflet capture, you can see that here is precise primary chordal placement supported by LCD optical monitor. This is very similar to the DS1000 system that we used before, but rather than 4 optical dots, we now use 2 to be able to confirm leaflet capture. The anchoring actually is quite simple. The multiple chords can be actually used on a single anchor, and then you basically simplify the tensioning by with one single anchor that is located in the papillary muscle. And finally, by doing the active tensioning in a beating heart under TEE guidance to really mimic the native construction and reconstruction of the mitral valve and also preserve all physiological function as well. So what has been the first human experience in the Nexus system? Well, there have been 3 patients successfully treated. The patients have been discharged typically on day 4, and 1 patient who's just recently treated has been discharged since. There have been significant MR reduction that's achieved acutely and has follow-up. You can see that here, at least what we found so far have been traced in all 3 patients. The anchor, one of the most challenging aspects of this procedure, has been stable and durable so far, follow-up with no pull-through or dislodgement. And actually, the patients, the first 2 of them has already completed 6-month follow-up, and the last patient has just been completed their discharge and will be followed up shortly. So here's some of the cases that have been done so far. As you can see, it's a 55-year-old male, prolapse P2 with flail, NYHA class 3, very low STS score, certainly not a high surgical risk patient. You can see here mildly reduced EF of 42%, normal, near normal to dilated ventricle here, in this case, dilated atrium, paroxysmal AFib, and you can see that here the patient did have cancer and also has other valvular disease as well. So the case planning involves both TE and CT, and because it's a transeptal system, we use CT to identify the fossa for ideal transeptal access, and also where the papillary muscles are for anchoring in the target, and also see what the distance might be, and you can see that here. Here's the pre-implant here. You can see the obvious P2 prolapse and flail, pretty advanced disease. And you can see that afterwards here, with complete leaflet restoration of coaptation of the posterior and anterior leaflet. There's no annuloplasty involved because typically, like the DS1000 transapical system, will require sufficient anterior leaflet to annular ratio to be able to restore optimal coaptation. So again, this is a pre-implant. You can see severe anterior directed jet with severe MR. And you can see that here in the post-implant, no MR at all. Here's a 3D picture. You can see a very large, broad P2 flail. Surgically, what you essentially would do, the 2 options, either a limited triangular resection and then with sliding plasty, or you can obviously also do chordal replacement as well with an annuloplasty band for reinforcement. However, with the chordal replacement, obviously you're not going to have an annuloplasty solution here. So you can see that after the chordal replacement with more than 1 pair of chords, the prolapse and flail essentially have been reduced. And you can see the MR went from severe to trace on the lower right corner. So here's a ventricular view of the repair valve. You can see that here. Anterior is on the top, posterior at the bottom. You can see the 2 chords here that are quite echogenic, and then the papillary muscle anchor here. So this procedure is quite echogenic and very eco-friendly. I think this is one of the key aspects of this procedure. And we have seen that, of course, also with the transapical approach that has been developed previously. Now, as I mentioned before, one of the limitations of this class of technology is the anchor pull through and pull out immediately after the implantation or shortly afterwards. That has been the Achilles heel of other similar technologies. However, you can see that here at CT at 30 days, by anchoring the anchor, placing the anchor directly at the base of the papillary muscle, you minimize any kind of gap across the trabeculi, and you can really secure it, just like what we do in surgery, where we place the base of the cords at the base of the papillary muscle before we tension it. And you can see that here at 30 days in transthoracic echo, the anchor placement, and also with really minimal MR. Now, how does it look in necropsy? So these are obviously pig models that were chronic animal implants. You can see that the anchor is right at the base of the papillary muscle. You can see the cord origins at the bottom of the papillary muscle, make it look more physiologic and anatomic. And you can see that the new cords are actually in the same fanning from the papillary muscle that is supposed to derive from. You don't want to crisscross these cords across the midline, and that will not be an optimal repair. And you can see that by doing at the anterior lateral papillary muscle, you maintain the native anatomy, mimic the anatomy. You can see that in histology at 90 days, that is completely healed and endothelialized and basically mimic the native cords. You can't really tell the difference between the two at all. And the anchor as well, you can see here, has completely healed with the adjacent papillary muscle. So in summary, the Nexus system is a very safe procedure. It's purely transeptal percutaneous venous system. Has excellent catheter performance maneuverability. It really mimics almost like a MitraClip in terms of versatility. And this system has the additional advantage of having the optical confirmation you saw earlier to be able to show that you actually have successful leaf-like grasping. And you can see that also you can place multiple cords at the same time on one single papillary muscle anchor. I think that's very important in terms of minimize the real estate that occupy these anchors. So far, at least with this system, the anchor has been stable with no pull through at 6 months. And you can see that the patient can be discharged relatively early, shortly after the procedure. So I'd like to thank you very much for your attention.
Can you hear me? Now I have changed my, okay. So
I think we have Tang on board right now.
Yeah. This is
hello.
Okay.
Okay. Now Professor Gilbert is online, right?
Yeah.
Hi, Professor. Yes. Thank you for the presentation. This time I want Professor Maisano to consider to make her considerations and make a question for Professor Tang. Please, Professor Maisano.
Thank you, Pablo. So Gilbert, well done. Obviously, it was very much expected this step up for the neocord. In my experience, I've been working with adjustable cord in the past with a different technology, and the main issue I had overall, the main issue always with adjusting device, with adjusting procedures, adjustments is always more difficult than the others. And specifically in this case, if I understand well the methodology, you have a catheter which is in contact with the anchoring system on the papillary muscle, and obviously this is a transmitral. So how do you avoid to have MR due to the interaction of the delivery system to the leaflets?
Hi, Francesco. Great to see you. Hope to see you in person soon. So yeah, no, this technology, as you know, started with transapical. That was actually commercially available in Europe. The issue is that, at the time, transapical is more invasive. So for higher risk patients, it might not be as ideal. But low risk patient, we're part of the trial that the results have been actually, we're 5-year follow-up now. It really amazing. You see a no residual MR and the LV remodel. The transeptal platform, of course, is not surgery. So I think that makes a big difference. And so the more the devices out there, I think the challenge is not just grasping the leaflet, which in this case, the NeoCord system, the transeptal, we're still using the optical conformation you saw in the animation. So that allows you to make sure you actually have a leaflet grasp before you enter the create the cord. The second point is the anchor. As you know, you've been involved in many technologies. The anchor is a challenge in terms of pull through. There are other devices that have situation where you deploy the anchor and immediately after you finish the procedure, the anchor migrated or dislodged the next day. So with this, so far, there have been 3 patients done. There have been no acute dislodgement in 2 patients. One was done with Thomas Modine. And then the one, as you know, was done by Stefan recently, when Baderleven, and then another one done. And they've all have a 6-month follow-up now that you saw in the presentation. The anchor remains. So I think the key with this technology or in any other corner replacement technology is to place the anchor at the base of the papillary muscle. And you and I, both surgeons, know you don't want to get into the trabeculi because then you have a gap. You can create a space, and the anchor may not securely fasten into the muscle itself. Your other question about tensioning is also critical. With the apical procedure, it's easier because it's shorter distance from the apex to tension, and you can tension multiple cords. With the transeptal system, you're more limited. You have to tension more one pair at a time before you deploy the second pair to tension, and you have the whole distance from the mitral valve to all the way to the venous, to the right femoral vein. So that is being worked up, and as you saw, it's very isolated P2. It's not a broad extension. It's not you need the multiple cords. You know that from the NeoCord experience as well. Those are the patients probably the best in terms of results and outcomes. But so far, we have not seen entanglement in the cords, also probably because we respect the plane of chordal distribution. As you know, as a surgeon, we aim for the lateral papillary muscle, which is a little friendlier than going medial because medial is more difficult and it's more branch. So because it's also, again, P2 prolapse or flail is right in the middle, there's really no cords in the center of the valve, just when you do, tear. So you can go into the ventricle and the anchor appropriately with the shaft and be able to deploy without catching other cords. But the key is to grasp the leaf at the right location the first time so you don't catch another cord as you grasp. That will be a problem.
Fantastic.
Excellent.
Gustavo, what do you think?
I just would like to thank Gilbert, Professor Gilbert. We know that he's in a very important meeting for the Apollo trial, and he took like a little bit of time off from the meeting to help us to discuss. Thanks a lot, Professor.
Thank you. Have a good rest of the meeting. We'll see you soon, Francesco. Ciao.
Bye. Congratulations. Great work.
Okay, now we have to move on.
We have 10 more minutes to discuss and to listen. What do you think about Rodrigo, Sarraf, Márcio?
Yes,
what do you think about all those 3 devices?
Pablo,
okay, question.
Yeah.
Question
Yes.
from the chat.
There is a question from Juan Ignacio Majoli from Uruguay, and he questions about the concerning after procedure on tricuspid valve about the function of the right ventricle. And the question is, what about right ventricle failure post-procedure? How do you manage this issue, Professor Maisano?
I didn't understand exactly. Sorry, I was not. I didn't hear the end of the question.
How manage the right ventricle failure post procedure in a tricuspid valve?
Yeah, because I was thinking. I was following the question until one point, and then I lost you because there are many issues there. Okay, so how you prevent failure? First of all, this failure doesn't happen so often. It's an overestimated issue, number one. Even the first in man we did 1 year ago, to be honest, didn't die of heart failure. The cause of death was ongoing multi-organ failure, because she came with multi-organ failure. She did not recover from multi-organ failure. But still right ventricular dysfunction may happen, I think there are two conditions that I would focus on, besides patient selection, which we don't know. I mean, patient selection, let's be honest. If you read the papers, there are probably more indicators than data. There are probably 100 different indicators, MRI, echo, strain, whatever. You can use it whatever you want. Well, I think is if you treat patients who have a very reduced contractile function, either in terms of longitudinal or radial, you need to be sure that this is not due to pulmonary hypertension, first of all, because this is going to be probably a real problem. You will have these patients undergoing an afterload mismatch. Although we need to also we need also to understand that pulmonary hypertension in some occasions is due to volume overload. So bottom line, these patients require multiple assessments in different times, particularly those who are a little bit more advanced. You need to take a decision based on clinical conditions rather than on numbers, in my opinion. You need to see whether they have some degree of reserve. You need to find the reserve, organ reserve, functional reserve, whatever. And you can induce this reserve by prehabilitation. So you put the patients on high dose diuretics and some inotropes or inodilators. And then, very important, I believe, is what happens afterwards, because that is a fundamental point. So, number one, if the inodilators work somehow better prior to the procedure, never use them after the procedure, because you need these patients to be on a high pressure system, because they will have potentially an afterload mismatch, and they may go into a ischemic state if you have too low systemic pressures. So you need to keep a good systemic pressure, number one. Number two, the best way is to achieve this by reducing to the minimum possible the volume overload. And this takes days. It's not one day. It takes 2-3 days before you find the balance, because many of these patients have a huge volume in the venous system. You know, again, imagine the veins in the body it's a huge volume. We don't know yet. I mean, I would like to learn it. We're not learning yet. So it's a combination of prevention and also of post-procedural management. But to be honest, the main issue is when you do replacement for edge to edge, you never see a real problem. If the patient cracks, if the right ventricle is not pushing well, you have a residual TR. You know, that will be not a big deal.
I agree, and I think this brings us back to the concept of prehabbing the patient, because one thing I've noticed in these patients is that you can easily diurese 15, 20, 25 liters out of them before you bring them for tricuspid procedure, whatever that may be, whether it's a ring, clip, Pascal, TTVR. So I think that's one. And then we just finished a review that will be published soon, hopefully in the next couple of months. I think another aspect that has been in the research area for well over 60, 70 years, but we have never talked about it in clinical practice, is pressure volume loop. And we have learned a lot from a number of cases that I have personally done. And we're putting in, hopefully, an algorithm that we can do pressure volume loop. And there are probably ways that we can do non-invasive PV loop, and understanding the details of the PV loop in these patients probably can tell us that which patient is best for tricuspid valve replacement, which patient is best for tricuspid valve repair. And I think one of the lessons that I have personally learned from Everest 2 trial is that, as the saying goes, that the enemy of good is better. We should not necessarily shoot for perfection. We should shoot for optimization. If we can reduce the tricuspid regurg to the point that the physiology of the patient goes back to normal, that's all the patient needs. We do not want to treat an image. We want to treat the patient. So what difference does it make if the patient, if we can bring it down from 4+ to 1 to 2+, that eventually, well, with whatever system, eventually will correct the physiology or pathophysiology to the point that we can get the patient over back to the normal Frank-Sterling curves. Rodrigo, what do you think?
Yeah, I agree. I mean, it's difficult. I mean, we are not used to work with the PV loops, but of course we have to adapt our results to first the possibility of implanting a device. I mean, you cannot select patients for edge to edge with 2 centimeter gap, 1.5 centimeter gap. This makes no sense. We have to adapt the devices to what we can achieve to try to get a minimum of our result. But at the end, what is important is the physiology. To try to restart a little bit or going back again to something that is tolerable for the patient to improve clinical outcomes. And I think at the end, this is the point. What I copy what Francesco said. It's important. Is what we did with our last cardival patients, and they are doing really fine. And with the edge to edge, you never have a problem. And I think if you live in moderate TR, it's enough for them. I don't think. I mean, more than moderate, I'm not sure it will work because it won't maintain over time. But moderate, I think moderate is fine just to normalize the right ventricular function. I mean, functionality, not function.
Okay, Adolfo, can you talk to us about your considerations, final considerations, please?
I think that everything was said. I appreciate the comments of both, the experience of Francesco and the good comment of Sarraf. We are treating patient, no images. So especially in the right side of the heart, you may consider to reduce the problem probably as a first step, and then to try to look for perfection. I don't have much to say. They both said everything.
Okay, great. Gustavo, just before we go to the end of the session, I just wanna make one comment. 1 minute. It's gonna be very quick. I think I want to thank you all for the opportunity to be here. I don't think I would be here because it was fantastic and so futuristic. But I want to say to you and Márcio and Pablo and Ginaldo and all the friends that this initiative that you guys have made through the 2 years of 4 valves is amazing, because Brazil is a very continental state, country, as you know, and we had some difficulties to bring these procedures, this complexity to the small centers. And just like me, I live in the countryside of São Paulo, and after 4 valves, I think a lot of our friends through the country are doing these cases, and not only São Paulo or Rio or big cities. And this is all to you guys that are doing this great job. Okay, thank you so much for your support.
Good. Thanks, Pablo. We are just a big team. There is that have many players, as you, as all the guys at the WhatsApp group and that are watching us at YouTube, and all our coaches are guys like Sarraf, like Rodrigo, like Maisano, like Tang that showed up here and give us a little bit of the future. Thanks a lot. And to close, I would like to turn a little bit for Portuguese because Márcio will make the information, will give the information about our presential meeting that will be upcoming in October. Thanks a lot, guys. Go on, Márcio.
Okay, thank you, Gustavo. Thank you, Pablo, for the words. And after this fantastic session, with inside of a Shark Tank, I feel like this, watching the sharks swimming. It was really great. And let me change to the Portuguese. So, então, a partir de agora, vocês já estão sabendo, os dias 14 e 15 de outubro, vamos fazer o nosso primeiro evento presencial, um evento para 40 pessoas, direcionado para o ensino. Acho que esse é o objetivo do For Valves. Hoje nós somos cerca de 700 médicos em 3 grupos de WhatsApp e 1.600 pessoas no canal do YouTube, mas a ideia, a gente acredita que a transmissão, a difusão do ensino, ela é feita de forma mais direcionada, como nós aprendemos no CAS com o professor Maisano. Então, 14 e 15 de outubro, marquem a data e esperamos encontrar vocês aqui em Brasília daqui a 6 meses. Obrigado, pessoal. Parabéns. Obrigado a todos aí. Thank you, everybody.
Tchau, graças.
Thank you so much.
Thank you.
Tchau.
Happy birthday.
Oh,
That's it.
thank you.
Great pleasure.
Fecha aí, Pedro.
Fantastic.